All right, so now we're going to transition to our hospital level presentations. We'll have 3 presentations that will go sequentially, and then we'll have the last 15 minutes for open discussion and question and answer session. So our first, I am thrilled to introduce Jennifer, or Jenny, as we warmly refer to her, Coach Zaffel. She is our CHoSEN Quick Prenatal Navigator Program Manager. She's also with the Kempe Center for the Prevention and Treatment of Child Abuse and Neglect here at the Anschutz Medical Campus. Jenny has been, I don't want to use the word given, but really volunteered wholeheartedly to lead this effort to integrate perinatal navigator support for mothers with substance use disorder as early as possible in that perinatal period, early in pregnancy. So she'll be providing an update to the group.
Hi, everybody. Thank you, Susan. I'm so happy to be here. I am going to share my presentation. Okay, Cassie, did that work? Can you all see the, okay, perfect. So
yep.
As Susan had stated, I'm going to give you a brief overview of our CHoSEN Quick Perinatal Navigator Program. I will share with you sort of how this has all started, where we are now, and where we hope to go. So where we started, oh dear. So our project started with outreach from Dr. Wang to our Executive Director, Dr. Kathy Wells at the Kempe Center, to see if the Kempe Center might be interested in helping to develop a program expanding the work of the CHoSEN program towards greater consideration and inclusion of child welfare. And so Kempe's long history of working with the child welfare system and Dr. Wells' longstanding work on issues related to substance-exposed newborns just made this feel like a natural partnership. And so the Kempe Center said, absolutely, we want in. The partnership really presents a unique opportunity to pilot processes by which we build upon current initiatives while better coordinating right now between Denver Health Programs and the Denver Department of Human Services. So we brought together an amazing group of people from the University of Colorado and Children's Hospital, Denver Health, the Denver Department of Human Services, Illuminate Colorado, to discuss the development of this program and to think through the following questions. So some of the main questions that we are really trying to think about and answer are how do we better engage prenatal providers? And so we're curious about learning about any concerns that prenatal providers may have about making referrals. I don't want to also forget to mention that we also want to make sure that pregnant people are comfortable with referrals too. So we want to learn more about how we can make people feel good about a referral being made and make them feel safe about what we're intending to do. We are thinking about how we can make the referral process quick and easy. We are thinking through what the notification process would look like to link services. I'll talk a little bit more about within the Denver Health System. We will be using the Epic. We will be using Epic, so we think that that will work. But we need to think about how we'll do this for any referrals that come from outside the Denver Health System. And we are also thinking about what we can do after pregnant people have their babies and they go home. So what can we do post-delivery and longer term to help support parents? So where we are today, currently we are piloting just within the Denver Health System. And so we are piloting the Navigator program within the Nurse Family Wellness Program, which is a Denver Health program and contracted through the Denver Department of Human Services. We've spent the last couple of months exploring and working with the Denver Department of Human Services on how we can utilize services available through the Nurse Family Wellness Program to support pregnant people with substance use disorders without involving child welfare. And so we have had some really productive conversations with the Denver Department of Human Services. They are just an amazing partner to think through the challenges around this. It has been a little bit of a challenge as we've thought through this because the family wellness nurses can't take, right now they cannot take referrals that are not child welfare involved due to the contract. So we're starting to look at the possibility of having perhaps the Denver Health Baby social worker provide that role right now, or an intern. So those are sort of the ideas that we've had around addressing that challenge. We have also been spending a lot of time learning about other similar programs, such as the Integrated Care for Women and Babies program, the program at Lutheran Hospital. We've been talking to Denver Public Health as well, because they are also working on some initiatives. And so really just trying to understand other similar programs being offered throughout the Denver health system and the greater community, with the thought that that will help us to focus the development of the Navigator program on ways in which we can provide complementary services to pregnant people. I do think that, we may be finding ourselves duplicating some services, but we really want to be intentional about that. So if we're duplicating, we want to have a good reason why. And then identifying potential pathways for pregnant people to come in to our Navigator program. So where do we hope to travel? As of right now, we're thinking that the Navigator program will be able to bring pregnant people into our Navigator program through a few different pathways. The first is through a referral from the Integrated Care for Women and Babies program. So in talking with them, we have identified that one gap that ICWB has identified is nurse or social work educator services on infant-specific education to pregnant individuals. So that is a gap that we can fill. And so we are looking at the Integrated Care program referring pregnant people to us, to the Navigator program, so that we can provide that education, that nurse or social work education. The next potential pathway would be through the Denver Department of Human Services through child welfare. So every once in a while, it doesn't happen very often, but every once in a while, child welfare will receive a phone call regarding a pregnant person who is using. And so sometimes that comes in from that pregnant individual. Sometimes it comes in from family members. Right now, child welfare can't do anything with those phone calls if there's not another child in the home that is at risk. So we're working with the Denver Department of Human Services to see how those phone calls could be forwarded to the Navigator program. And then we can do outreach to that pregnant individual and get them hooked in with services that way. The Denver Department of Human Services also has a complex care unit. And complex care is not part of child welfare. So that's part of the Denver Department of Human Services that serves the greater community. And so we are also talking with DDHS about whether or not we might be able to identify pregnant individuals through the complex care unit and how we would have them referred as well. And so, right now we're thinking about whether or not something can be put into trails, and then the family wellness nurse can pull those referrals. So we're just sort of doing some brainstorming with them to see how that could potentially work for us. And then finally, we are also just exploring other programs through Denver Health that the Integrated Care for Women and Babies program may not serve. And so just thinking about how those would come in to our program as well. So some of the, there have been challenges, right? Anytime you're trying to link services and work with big systems, there will be challenges. Probably a little surprise to everybody, but one of the greatest challenges has been where are we going to put the data so that it can be pulled in a comprehensive way and can show a comprehensive picture. So like I had mentioned earlier, right now with the Denver Health pilot, it's looking like we'll be putting the data into Epic, which we think will work well within the Denver Health System. But we do need to be thinking about if we're going to be getting referrals from the Denver Department of Human Services or from other community agencies, where will that data go if that pregnant individual is not hooked in with the Denver Health System? So that's been one challenge that I think that we've spent a lot of time really thinking about and talking about. Again, we've worked with the Denver Department of Human Services and thinking about that too. And it has just sort of raised this greater question around the need for a statewide or universal data tracking system. So we're looking forward to continuing that conversation as it relates to how we can better link and how we can better track data. So I know I got through that pretty fast, but what questions can I answer?
That was great. Thanks so much, Jenny. We're going to do questions at the end of this session. So we'll have 2 more presentations and then have an open discussion. And I'm sure there'll be lots of questions that will come up. So thank you. Next, we have Dr. Bridget Buzzella. Dr. Buzzella is the Regional Medical Director of Neonatology in Colorado and in Kansas. She's also the Medical Director of Neonatology at St. Francis Medical Center. And today she'll be sharing with us her experience of standardizing care both at an individual hospital and perhaps considering expansion to a systems level approach. So thank you, Dr. Buzzella, for joining us.
Great, thanks for having me today. Let me share my slides. Oops. There we go. Can you see them?
Yes, that looks great.
All right. Great. So I was asked to share our experience rolling out Eat, Sleep, Console at St. Francis Medical Center. And this really was a Centura-wide initiative. And we had collaboration. It was really a comprehensive kind of process with support from Centura Healthcare. So we had a team of physicians, APPs, nurses, pharmacists, IT, and a facilitator support person to help us kind of collaborate and roll out this initiative in a way that made sense for all of the hospitals within the health system. We created all collateral materials, including a Learn module for the nurses and for the staff, for physicians. We created talking points. We created educational material for parents. We had some members that participated in the CHoSEN collaborative on our committee as we were creating this, and they provided some great kind of resources and input into how we were developing the program. We then developed a tool in our EMR, which is Epic, for the nurses to document and for the team to kind of review how the baby was doing in our electronic medical record. And then develop some tracking tools with our support from Centura IT department in something called Power BI, so that we could extract the data and kind of review how we were doing as the program was implemented. And then it took us probably a little over a year and a half to kind of work on all of these different parts and pieces. And then implementation went live last June. Next slide. So one of the things that we created was a Learn module for the nurses. And because this is sometimes an infrequent process in some of our hospitals at St. Francis, our NICU educator also created binders for the nurses to refer to because it may have been some time since they did the Learn module, so that they could have a refresher case-by-case basis for the baby and keep it at the bedside. And so, I'm sharing a few screenshots just on the Learn that we created. So it was something new for Centura in our approach to treating substance-exposed newborns. And we created this comprehensive presentation for the nurses and talked about, what was Eat, Sleep, Console, and what kinds of things we were measuring that was different from using the Finnegan scoring tool previously. And then we provided some details for the nurses and for the physicians that were caring for the babies or the APP providers, so that we were doing this screening for all substance exposed newborns, what the assessments around care would look like for the baby, when we should initiate the Eat, Sleep, Console process for the baby, and then how long we should potentially monitor the baby in the hospital if we had some opiate exposure. And then the big change was that the infant would be assessed in their own room and stay rooming in with their caregiver if it was appropriate. And then the assessments would be every 3 to 4 hour intervals, and that we should elicit the family's feedback and involve them in the ESC process. We also provided some reasons behind, or what the research showed into why we were looking for this change. So we were looking to reduce medication treatment rates, decrease the length of stay for our babies, and then overall patient satisfaction and parent involvement in the care, to give them a better set of tools to be successful at home and caring for these babies. We also wanted to make sure that we focused on the great things that ESC has to support the babies, or the kinds of comforting things that were going to help this be successful. So rooming in with the mother whenever possible. We have all single patient rooms, either on the postpartum side where the moms and babies were if the baby did not need to come to the newborn intensive care unit, or private rooms in the NICU. And then we provided a minimally stimulating environment and educated the families around that and the benefits of swaddling, holding and rocking, breastfeeding, non-nutritive sucking, skin to skin contact, and then the family piece and being involved in all of this. One of the great things that we were able to do also for support, if there was a family member that was not able to stay with their baby, or the nurses were busy in the NICU if the baby made it to the newborn intensive care unit, is that we set up a cuddler program. And the cuddler program is available 24/7 in our hospital. We can call them, in the middle of the night if we're struggling with consoling a baby and just needed some more support. And then we developed the process. So, we admit the baby under the ESC assessment, and then we followed some algorithms that I'll share with you on the next slides, and then making sure that we're training the staff to rescreen the baby every 3 to 4 hours. This was the algorithm that we created for Eat, Sleep, Console, probably similar to what you all did with the CHoSEN initiative, but just something for the nurses to refer to and for the medical team to refer to and follow the steps to make sure we're on the path to treating the baby appropriately. And then we worked really hard on developing our EMR so that it was a functional tool for the nurses to be able to document what was going on with the baby. So we developed the Eat, Sleep, Console into the Epic system. And then developed, all the different metrics that we needed to follow, with guidelines and information for the nurses to refer to as they were charting. So this is the sleeping piece that we created in Epic. And then we did the same for the eating piece and for the consoling piece here. And then we developed flow sheets within Epic so that we could see what was going on with the baby, with all the different metrics and the consoling measures that the staff were using to support the baby. After that, we created a medication algorithm so that we were all practicing consistently. And a big piece of the medication algorithm that was a change for most of our facilities is picking one choice for opiate and consistently using that same opiate with a defined dose, and then moving towards more PRN dosing if a baby did fail the ESC measures and escalate to medication administration. So there's a pathway here for PRN treatment, and then if we're needing to give very frequent PRN treatment, then there's a pathway for maintenance dosing. And then we created a data platform so that we could keep track of what we were doing, and capture all the great things that were benefiting the babies for in terms of using Eat Sleep Console. I blocked out, because this slide shares all of the hospitals, so I kind of blocked out the names of the hospitals. But we created this so we could look at the length of stay for the babies, and now we have this system in place at all of our Centura hospitals so that we can compare facility to facility, look if there are variances in practice or opportunities for more education or improvement. We're looking at how much morphine we're actually utilizing. And I did not kind of share a screen from before implementation, but we were really using almost 100% morphine at St. Francis for babies that were opiate exposed. And we've significantly been able to reduce our opiate use to very little, and almost never using scheduled dosing anymore, but just a couple of PRN doses on a rare occasion. Really have consistently been using one, and then if we have a polysubstance abuse patient, using clonidine in conjunction. We've been able to reduce our length of stays significantly, and then eliminate our use of methadone and phenobarbital for the patients within Centura. And then this is another slide just to show the data capabilities. We're still kind of tweaking our coding because the coding is entered sometimes by the CNAs, the secretaries, or the nursing staff. We still have a lot of babies that are coded as unspecified in our EPIC system, but we know that they are substance exposed babies. So within this report by facility, I can actually pull up baby by baby to kind of dig into the documentation from the providers. But we're trying to hone in a little bit more so we can have less patients coded as unidentified and more specific coding to make this data platform more valuable and less time consuming to tease out all of the details. But you can see again, they are listed by Centura facility and the volume of babies, our length of stays, what percentage of the babies end up in the NICU versus staying out in the well baby, and then what medications we're using. And so it's really been fabulous to be able to have some data to look at and evaluate how this has changed our clinical practice and outcomes for our patients. Thank you, and that's all.
Great, thank you so much, Dr. Buzzella. That data dashboard was the coolest thing I've seen in a while related to data. Oh my God, it blew my mind. All right, so let's move on.
It's pretty awesome.
Oh, I know, it's amazing. I never even knew such a thing existed. Goodness. All right, let's move on to our third and final hospital level presentation. It's my pleasure to introduce Dr. Lauren Bruns, who's an assistant professor of pediatrics at the University of Colorado School of Medicine. She's also a newborn hospitalist at Denver Health and is also a member of the CHoSEN Quick Collaborative Steering Committee and is also co-chair of the Plans of Safe Care Work Group for the CEN Steering Committee. And today she'll be sharing with us her experience around Plans of Safe Care at Denver Health.
All right, thank you, Susan. I'm gonna see if I can share my screen. It looks like Dr. Buzzella may have to hop off.
Yep, Dr. Buzzella, you may have to stop screen sharing so that Lauren can share hers.
Great.
Perfect, thank you.
Let's see, okay. All right. Okay, well, thank you guys so much. I wanted to kind of briefly start with a background of the Plans of Safe Care at Denver Health, and kind of give a quick, just broad overview of where the Plans of Safe Care came from, and then how we were able to integrate it with our system at DH. So one slide, just kind of very brief background of Plans of Safe Care. So CARA, or the Comprehensive Addiction and Recovery Act of 2016, was a modification to CAPTA, which addressed child abuse prevention and treatment. And that essentially mandated that the child welfare system develop a plan of safe care for any infant who was identified as affected by substance abuse. And there was not a ton of direction regarding the plan of safe care, apart from the fact that that it must in some way address kind of the physiologic medical needs and readiness for discharge of the infant, address kind of complex discharge planning, follow-up care of both the caregiver and infant that would address any of the infant needs as well as any of the substance abuse needs of the caregiver, and then overall just kind of readiness and education of that caregiver. And ideally that this is developed with a group of multidisciplinary medical providers that include both mental health and substance use disorder providers, maternal and pediatric care providers, as well as our social workers, and support from our child welfare colleagues. So I think a big thing that that is important to address is the fact that that it's really important that we as the birth hospitals are collaborating with our child welfare colleagues. And so per the Administration for Children and Families, which is a part of the Department of Human Health Services, the development of plan of safe care is required whether or not the circumstances constitute child maltreatment under state law. So what that means is that we can't rely on our child welfare colleagues to create a plan of safe care for every baby who's born substance exposed, because there are going to be infants who are born with in utero substance exposure who don't require any sort of support or contact with our child welfare services. So I'm sure that many of us have encountered families in some regard in which the caregiver, the pregnant person, was stable in an MAT program during pregnancy, is well supported. That infant may still experience withdrawal symptoms and still needs to kind of have a multidisciplinary approach to that child's care, as well as the substance use needs of those caregivers. But we don't need child welfare involved in that case. But a plan of safe care would still, I think, benefit that entire family. So I created this, this kind of visual representation, which is not reflective of actual data or proportions. But if you think about all of our substance exposed newborns, there is just going to be a subset in which there is also a concern that for child abuse or neglect. Once that report is made to child welfare, they may or may not screen that in as an infant for whom they have concerns. So if you were to think about relying only on our child welfare colleagues to create the plan of safe care for infants, you're going to miss this entire subset of babies. So really, if we're asking our child welfare colleagues to be responsible for creating and kind of initiating the plan of safe care, we're really only going to see that for the infants for whom there's concern for abuse and neglect, and for whom kind of a report is ultimately made and that baby is screened in. So at the end of the day, I think we can all agree that we just want to take better care of our infants and families. And so that it's really important that we as kind of the support group for medical providers and prenatal and pediatric providers are collaborating with our child welfare colleagues. So that kind of brings us to where we are at Denver Health. So we essentially took the Colorado Plan of Safe Care, which is right here, and that was created in collaboration with medical providers, child welfare folks, and is available online. And this is essentially kind of addresses everything that needs to be included in a plan of safe care. So it talks about the readiness of the infant, it addresses the discharge planning, it addresses the follow-up needs of the family and the infant, and it addresses the readiness and education of the caregiver. So what I did is I essentially kind of took this and embedded it within Epic. And I recognize for some of our non-healthcare providers, it's kind of hard to see what that might look like. So I'm going to go out of this and show you guys what this actually looks like within Epic. And this is a simulated environment. So none of these babies are real. So there's no sharing of any PHI. So essentially, this is our virtual nursery, and this baby, let's say, was delivered 5 hours ago, and I, as the inpatient nursery provider, am preparing to go and talk to this family and admit this baby to my nursery. So every baby, and really kind of every patient who exists within the EPIC electronic medical record system has a problem list. And the problem list includes things like, somebody who may have asthma or diabetes. Any of those medical issues are placed in the problem list, and you are able to kind of open that problem and essentially get an overview of that problem. So for example, somebody who has a diagnosis of asthma, the provider who is taking care of that patient's asthma may, in this overview, say that this patient has a history of allergies and they've been admitted to the hospital, X amount of times, they've required ICU level care, X amount of times, this is their current medication, they were last on steroids for their asthma, however many days ago. So we utilize this problem list as essentially an overview of any one of our patients' cares and their most, I think, kind of pressing medical issues, I guess. So for our newborns, every baby will have the problem of a newborn, and this kind of includes just the overview of that baby's care and birth. And then for this baby who had in utero substance exposure, we'll say that baby had exposure to methadone and is at risk for withdrawal. And so in order for us to incorporate this plan of safe care into EPIC, I created what is essentially kind of a shortcut phrase where if I put .safecare, that will pull in the EPIC version of our plan of safe care and auto-populates those patients' demographics, medical record number, and then allows providers, as this patient is hospitalized, to go through and update kind of what in utero substance exposures that baby had, how long they were in the hospital, if they required therapy, and then it allows us to input data about the household members, any emergency contacts, and then all of the referrals that have been made, were made, or need to be followed up upon, and then identifies the home caregivers, what is that baby's feeding plan at the time of discharge, what medications is that baby going home on, when will that baby be seeing its pediatrician for follow-up, and then when will that mom be following up. And so this, by kind of creating it within EPIC, it essentially allows multiple providers to update this, and it is not quite a living document, but it at least follows this baby from the birth hospitalization into the outpatient setting. And what I have found is in just having created this and having these discussions with families, it has prompted me to ask questions of my families and to provide education that I wasn't necessarily providing before the incorporation of the plan of safe care within EPIC. And so I feel like it has prompted education and conversations with my families that is overall improving their care. So I'm going to exit out of this and then talk about how kind of where we are in terms of use of this. So some of the barriers that we did encounter was essentially getting education and buy-in from our nursery provider group to start using this in the care of our opiate exposed babies. So of course, nobody loves change, and this is a change to our typical workflow, and just having to remember that when a provider is admitting or taking care of a baby who is at risk of withdrawal or had in utero substance exposure, the provider is the one responsible for inputting that problem and then that plan of safe care that I created within that infant's problem list. So of course, if they forget to put it in there, there's no right now kind of safety net to make sure that a baby has that in their in their discharge summary at the time of them going home. It is, I think, as we are working into it, it's time intensive, and I will be the first to admit, like, this was my, my passion project, and I feel really strongly that this overall improves the care of our babies and their families. But it prompts me as a provider to go in and have conversations and ask questions that I wasn't necessarily asking before, and that takes more time. But I do think at the end of the day, it's going to improve the care of our families, and is prompting discussions that I was not having previously. One thing that has helped in regards to that kind of time-intensive aspect is our social workers traditionally were documenting outside of that problem list that I showed you guys, and it took some time to get them access to that problem list. But now our social workers are able to go in and document within that plan of safe care in that infant's problem list. And so they are able to go in and document referrals that they have made, kind of what mom's support system looks like. They're able to document the early intervention referral and things like that. So that has been hugely helpful and has taken some of the burden off of us as the medical provider. And then some of the other things, and this has come up quite frequently today, but is how do we make this visible and accessible to outpatient providers and our child welfare colleagues with it living within EPIC, and how do we make sure that we are addressing confidentiality issues and making sure that we're not disclosing information that is inappropriate to be disclosing to certain parties. So that is something that we are still trying to figure out and still working through. And then I think as we move to use of this in our outpatient setting, I've had the opportunity to meet with some of our outpatient pediatricians, and they have a different view of EPIC than we do as the inpatient providers. And so they have helped us in terms of making it more visible to them and allowing us to put in kind of FYIs or little sticky notes that that will come up, so that when a baby is discharged and is following up in the pediatrician's office, an alert will come up that says, hey, this baby has a plan of safe care, so that the pediatric provider knows to seek it out. Because oftentimes, even despite EPIC inbox messages about these families or warm handoff, because this is new, it's not often a part of our outpatient colleagues' workflow. So we're working on that as well. In terms of where we hope to go with this plan of safe care. So what I just showed you guys within EPIC is what we call a dot phrase. And so that's just a shortcut to embed text that's essentially like a Microsoft Word document. And it's great in that it is able to embed that plan of safe care within EPIC, but it's not necessarily a living document in the sense that that it can pull in new information. So it relies on the providers to go in and edit and update it. So what we are hoping to do is move from a dot phrase to a flow sheet, which looks like this. And it's sort of similar to the Eat, Sleep, Console flow sheet that you guys had seen with Dr. Buzzella. But basically the goal, and this is not, this obviously is not our plan of safe care flow sheet, but the goal, what we're working with EPIC right now, is to essentially turn the plan of safe care into this type of documentation process that will allow whomever is filling it out to kind of select from a series of options. And then ultimately that can then be translated into a note. And again, this is an example of this is the only thing I could find online, but this is essentially a flow sheet turned into a note for a patient who presents with a trauma. But this was kind of the only thing I could find when I was trying to explain what this will look like. But by doing that, it will allow us to pull all of that information within our plan of safe care into note-based documentation that can be updated in real time, and would also facilitate then the input, export, and analysis of data, so that we can ultimately kind of have improvement of the care of these families. We're working with our pilot program that Jenny discussed to incorporate this within our prenatal care period, and have identified some midwifery champions who are willing to initiate some of these discussions and some of this data collection in the prenatal period. And then I think, just like like Jenny was discussing, ultimately we want to do this so that we're improving the care of our families and potentially creating an environment in which child welfare may not need to be involved, because we've started addressing some of these issues and asking these questions and getting referrals and resources in place before the delivery of the baby. And ultimately, in order to do that, in order to kind of gather that data to prove, does this work or does this not, we would need to follow up on our child welfare outcomes, and then kind of figure out which resources and referrals were accessed and utilized. And so these are all kind of data gathering and systems that we're hoping to optimize here going forward. And I think that is, oh, and the last thing I did want to mention, so Epic has been utilized and discussed by many of the care providers, and 19 of our 30 hospitals within the CHoSEN Quick group use Epic, and there is the ability to, within Epic, to create a tool that then can be shared with other systems, sort of like an add-on. And so hopefully once this, our plan of safe care has been translated into the that flow sheet that I had shown you guys, ideally we would then be able to share that with other hospitals who use Epic, so that that can be translated across all hospitals using Epic, so that we're not reinventing the wheel, which would then hopefully kind of optimize our data entry and analysis. And then from a statewide standpoint, we're working with our Plan of Safe Care work group, recognizing that this Epic tool is not going to be relevant to some of our smaller community-based hospitals who don't use Epic. So what can we do, and what lessons learned from our kind of conversion of the Plan of Safe Care into Epic, how can we use that knowledge and that experience and those troubleshooting to make that work for smaller community-based hospitals who may not use Epic but have a different medical record system? And then while doing that, kind of educating and training our providers, both pediatric and prenatal providers, about the importance of the Plan of Safe Care. Because again, at the end of the day, I think we can all agree that we just want to take better care of our families, and by addressing all of these things upstream, just like Susan mentioned at the beginning of today, I think will improve the care of the entire family. So that's sort of hoping to be where we wind up. And if you guys have any interest in helping or learning more, there's some education modules about the plans of safe care that are available on those websites. And then if you guys would like to get involved on more of like a boots on the ground side of things, you can sign up for the Plan of Safe Care work group. Please feel free to email me, or you can get in touch with Illuminate, and they have some excellent efforts, not just focused on plans of safe care, but kind of across the board. So with that, I will exit out and stop sharing my screen. But thank you guys so much for your time.
Thank you so much, Lauren. That was tremendous. Now we have our question and answer and open discussion period. So feel free to either unmute yourselves or to chat in questions I could read aloud. There's one from Erica Wymore who asks, the ESD tool was shared with the Epic headquarters. Has this tool been pitched to them, meaning the plans of safe care tool? And do you think it could be more widely disseminated nationally with policy emphasis on plans of safe care?
So to my knowledge, at least about the ESC tool, we at Denver Health kind of have our own tool that's been used within Epic, but I do feel like that is sort of a tool like that. That's kind of the idea of what we are hoping to do with the Plan of Safe Care tool. But to my knowledge, that has not, at least I don't know about that having been pitched. But that is our hope.
And I have a question for all three of you, and that is, through your three presentations, we've covered prenatal engagement, birth hospitalization, and that postnatal transition home, and wondering about how you or your systems have interacted with the child welfare system as your programs have developed, what that engagement looked like, what were some of the barriers and facilitators, because I think for many here on the call, child welfare and kind of related services still feels a bit like a black box. And I think many at the hospital level are still uncertain about how to interface with folks from child welfare. We oftentimes leave that to our social workers, but clearly all three of you are providing care directly to mothers and infants. And so wondering, what that relationship with child welfare has been like for you all. So perhaps I'll start with you, Jenny, since you're at the prenatal piece.
Yeah, that's a really great question. I think what first came to mind, Susan, as you asked that, is that my experience with child welfare, and I've worked with child welfare for over 25 years, actually started in child welfare as a caseworker. I believe that they are committed to reducing contact of families with their system. And so I feel like for us, as we've talked about the Navigator program, Denver Department of Human Services has been very interested in having these conversations with us. They also want families to be well. And so in talking through, what is the best route for us to identify families and then bring them in for services, with the hope that as parents, as pregnant individuals move through their pregnancy, and have their babies, that maybe child welfare won't even need to be contacted. So for me, my experience with them is that I think they've appreciated being asked to be involved. I think they've appreciated being asked for their opinion. And I think that I have sensed some excitement from them in terms of being a partner in the conversation for how we can better serve families so that they don't end up in child welfare. I hope that answers the question.
Mm-hmm. Bridget, I'll pass it over to you, to speak about the birth hospitalization.
Sure. Gosh, I don't think our interaction with child welfare has changed with the implementation of Eat, Sleep, Console. Our social workers are so fabulous that they really engage and participate in most of this. I can imagine probably our referrals are less, but I think they're generally, I think like everywhere, short-staffed, and we don't feel a strong presence from them in Colorado Springs. Are you all having like site visits from child welfare, things like that at your hospitals in the Denver area? Oh. So we just don't see that in Colorado Springs.
Yeah, so some people are chatting in and saying that it sounds like in the Pueblo area, they are having a more visible presence of child welfare in that region. I saw Lauren shaking her head. I personally am not aware of child welfare kind of visits to our units at the Anschutz Medical Campus. So I don't think it's a frequent phenomenon.
Thanks.
Same question to you, Lauren, around, clearly the work that you're doing feels sort of naturally, you've got to work closely with child welfare, given that they are really overseeing how we operationalize plans of safe care to meet the federal mandates. But, I feel like the work that you're spearheading is broader than our need to meet sort of federal requirements. So curious to know what your interaction has been like.
Yeah, thanks, Susan. I think that that child welfare has certainly been very appreciative of the of the collaboration that we have created. And so as it stands, at least in the state of Colorado right now, even if the birth hospital creates a plan of safe care, if there is concern for child abuse or neglect and a report or referral is made to child welfare and they ultimately screen that infant in, they are also creating their own plan of safe care. And the discussions I've had with them is that they are not, they are not medical providers, and the experience that they have with substance exposed babies is just kind of anecdotal from what they've encountered. And so they really rely on the medical team and the birth hospital team for the information that is important to the plan of safe care. And so I think that by having buy-in and collaboration with birth hospitals, I feel like the feedback I've received from them is that they feel like they can do a better job, and that they can kind of do better for that family with the knowledge and information that we as the birth hospital and medical providers are able to provide.
And then a related question, for both Jenny and Lauren is, as your programs are developing, are you planning on a data system or some sort of process by which that information is shared with child welfare? And just thinking about the sort of legal hurdles that are involved, but also wanting to create some efficiencies in the system so that families are well supported, and not feeling like we're duplicating services at the same time.
Lauren, you want to take it first, or do you want me to go first?
No, go for it, Jenny. I can, go for it.
Okay, and jump in, please, because you've been involved in the conversation as well. You know what, Susan, I think that's like one of the $1 million questions, is how do we do that? But we have, in our group, we have talked a lot about navigating that. What does that look like? How do we, one of the things with the Navigator program is we would like to be seen, well, we are separate from child welfare, so we don't want there to be a link. We want to be able to gather information and have pregnant people feel like that's not being sent over to child welfare. So we have not found an answer to that question yet, but it's something that we've talked about for the past couple months as this group has come together.
Yeah, I was going to say that is the $1 million question, because I think trying to straddle the lines of respecting patient confidentiality and recognizing that we as people who work in the context of families, I think we can all recognize that addressing the care of our clients, of our patients, as a family unit is really, really important. But you then also have to kind of respect that each individual has his or her own kind of rights to privacy and things like that. So I think that is something that we have to be really mindful of. And one of the reasons that, it sounds like Alicia was saying that they have struggled with that as well. And I think that's something that for those reasons is hard. We did discuss, for those of you who guys were at the Plan of Safe Care webinar back in December, there was, I think Indiana has a system in which a family has a unique QR code that they can scan when they are accessing services, when they're seeing their pediatrician, when they're seeing their provider. And just by giving the onus of that into the hands of those families, they are choosing to share that information. They are kind of deciding when to scan that QR code. And then that information is all kind of put into a database, so you can follow up on what resources and referrals are they accessing. And that's one of the things that we have kind of thrown around as we're thinking about this pilot program, is how can we be respectful of confidentiality, of privacy, of realizing that these babies are attached to their mothers right now, but will not always be attached to their mothers. And so how do we respect that infant's privacy for when they get older, but still gathering data so that we can do better and kind of show what works and what doesn't.
And I'll just add, this is sort of where that discussion about a universal data tracking system has come in, and what are the possibilities around that?
All right, we have a comment here from Eric Weimer, who says, for families, separating child welfare from the Navigator program to quote unquote walk with families prenatally through the first year postpartum is essential. And I think that does highlight, perhaps the problematic history that individuals and even some organizations have with child welfare, but absolutely recognizing the services that child welfare could potentially provide to support these families. I think at present it's viewed through a punitive lens, but somehow if we could shift that to sort of supportive care, I think that would be quite helpful. Any other questions? A question for Dr. Buzzella. So, you are a regional medical director for really a system of neonatology. And so it's hard enough to do quality improvement in one unit, right? Change is hard, even for a small group of people. And so when you think about a system of several units, how do you get buy-in from these other units that may not have been perhaps the unit that developed this idea or started it? Perhaps you might have some providers that rotate through these different units, but oftentimes nursing, respiratory therapy, others are quite, distinct, and their home is that one unit. And so how do you really convince and engage so many players and units within a system to jump on board with this really important effort?
Sure. So I can say when we began this Centura-wide project, my role was exclusive to St. Francis. And now that my role has expanded to covering all of the Centura units, I learned so much about all the great things we thought we were doing to get this program rolled out at each of the facilities, that there are some facilities that had not rolled out Eat Sleep Console despite our best efforts. And I think it's engagement kind of on the ground floor at each of those facilities with the providers that are there, helping get that buy-in and that kind of successful implementation at the ground level. So what we're doing now is engaging all of our physicians and our APPs to champion all of the guidelines that we're hoping to roll out, and ESC is one of them at some of the smaller facilities that just didn't participate to the level we were hoping for. So that's involving the APPs to kind of champion and then get the staff excited about it, to look at the data and see what good things we've done in the other facilities so that we can get their buy-in. And then creating all of the tools that we created at St. Francis for the other sites, like the binders with the kind of real-time education that they can look through if they haven't done the Learn module in a long time. Because I think all of the staff was required within Centura to do the Learn module, but most certainly it did not get hardwired in the units that didn't have that provider kind of championing and engagement. So they've formed subcommittees now in each of the units and asked for nurses to join those subcommittees so that they can also be kind of the experts in Eat Sleep Console for their colleagues to refer to also. Does that make sense?
Mm-hmm. Yeah.
So a lot of work still to do.
Yeah, you had your sort of mini CHoSEN Quick within the Centura system. Our work started in just a few hospitals at Anschutz and Denver Health and quickly spread, but many of the same principles that you highlight. Can you get a champion at individual unit, form a team, and really create excitement and demonstrate results with data? So that's fantastic. All right. Well, thank you to the three of you for your participation, your energy and expertise. We really do appreciate it.